Hi everyone, welcome back to the third video of the lecture. In this video, we will cover the pharmacological treatment in diabetes mellitus, especially in the insulin therapy. As you can see here, the pharmacological treatment between type 1 diabetes mellitus and type 2 diabetes are slightly different. Insulin therapy is the only pharmacological treatment that works for type 1 diabetes, whereas the oral medications or oral anti-diabetic drugs are the first-line therapy for newly diagnosed type 2 diabetes with no comorbidities such as hypertension, no dyslipidemia, and no obesity. This insulin therapy is needed as a first-line treatment in type 1 diabetes mellitus, in the GDM, and to those who develop ketoacidosis. For the patient who is newly diagnosed type 2 diabetes mellitus with HbA1c more than 10% and the fasting plasma glucose level more than 30 mmol per liter should initiate this insulin therapy. They should be straight away treated with insulin therapy rather than giving them oral medication. Insulin therapy also is needed to those who fail to achieve the required target glycemic range, although number of oral anti-diabetic medication has been optimized. Insulin therapy in Malaysia are fully derived by recombinant technology or genetically modified human insulin. Animal insulin that derive from pork and beef preparations such as isofen, neutral, 3070 and lent are not available in Malaysia but is available in other countries. The type of insulin according to their pharmacokinetic profile, which are prandial insulin, basal insulin, and premixed insulin. As you can see in the chart here, prandial insulin was administered before or each meal. It has been administered pre-meal because it has short or rapid onset of action in controlling the postprandial glucose excretions. Basal insulin has intermediate or long-acting of insulin action. That is why it usually administered at the bedtime. The basal insulin covers the basal insulin requirements in our body. Meanwhile, the premixed insulin is a biphasic insulin that incorporates both the short or rapid acting insulin with the intermediate acting insulin into a single preparation to cover for both postprandial glucose excretion as well as basal insulin needed in our body. This is the prandial insulin that is available in the Malaysian markets. As you can see here, the rapid acting has 15-minute onset of action and short-acting insulin required 30 minutes to onset the insulin action. That is why we will counsel the patient to have a shot of insulin 45 minutes for regular insulin or 5 to 50 minutes for rapid acting insulin prior each meal. The most common prandial insulin that available in government hospital is atrapid, in which always given in the hospital by the nurses because it's in the vial form, or also the Humulin regular that can be used by the patient at their home basis. Atrapid is produced by Novartis and Humulin regular by Lilly's. The IV infusion of atrapid also practically to be used in the treatment of diabetic ketoacidosis and during the perioperative management of insulin-required diabetes. The basal insulin can be intermediate-acting insulin, which is NPH, neutral protamine hagedon, and long-acting insulin such as insulin glargine and insulin determinant. Insulatard and Humulin N are the NPH insulin that commonly used in our practice. We will advise the patient to take this insulin at their bedtime. The onset of NPH insulin approximately about 1 hour, and the duration can be up to 16 hours. The delayed onset of the NPH insulin is due to the combination of insulin and protamine that present in uncomplex form or called as isoform. After subcutaneous injection, it took time for proteolytic tissue enzyme to degrade the protamine to permit the absorption of insulin. Please bear in mind that this drug should be taken together with parenteral insulin that given 2 to 4 times daily for insulin replacement. As you can see here, insulin glargine is soluble in acidic solution but precipitate in the more neutral body pH after subcutaneous injection. This is due to the modification of insulin structure, which slowly dissolves away from the crystalline depot and provide a low, continuous level of circulating insulin. That is why insulin glargine has a slow onset of action, which about 1 to 1.5 hours, and achieves a maximum effect after the 4 to 6 hours. This maximum activity can be maintained for 11 to 24 hours or more longer. Thus, administration of insulin glargine should not be mixed with other insulin in one syringe or at any one time. As I mentioned before, intermediate-acting NPH requires supplements of short or rapid-acting insulin before meals to reach the adequate therapeutic levels in diabetic patients. For convenience, they introduce the premixed insulin. The premixed insulin is the combination of this rapid or short-acting insulin that mixed with intermediate-acting insulin. This combination works well by helps the body to control the blood sugar all through the day, as well as helps the body control the blood sugar at any meal times. This insulin should be given subcutaneously approximately 15 minutes before a meal. The most common premixed insulin that been practiced here in Malaysia is Mixtard 30 and Humulin 3070. The main advantage of this new mixture are that, first, they can be given within 15 minutes of starting a meal. Second, they are superior in controlling the postprandial glucose. They are superior in controlling the postprandial glucose rise after a carbohydrate-rich meal. So, how the insulin differs between one and another? As you can see here, this is the insulin structure of the Mixtard. As I mentioned before, Mixtard is the combination of intermediate-acting insulin, which is insulin NPH, the blue color multi-hexamer, and rapid-acting insulin, which is insulin aspart, the orange color hexamer. All these insulin are administered through subcutaneous. As you can see here, the insulin molecules exist as dimers that assemble into hexamers in the presence of 2 zinc ions. These hexamers are further stabilized by phenolic compounds such as phenol and metacresol. Recap back, 2 zinc ions will coordinate 6 insulin monomers to form the hexameric structure on which the matured insulin crystals are based. This insulin hexamer has minimal diffusion. That is why they need to dissociate into monomer to rapidly diffuse into the blood capillary. The insulin aspart exists as hexamer are rapidly dissociated into the monomer, lead to rapidly absorbed into bloodstream. In contrast, NPH exists as multi-hexamer that cause slow dissociation into the monomer. That is why intermediate and long-acting insulin cover the basal insulin requirements.